Postural hypertension is a very common cause of collapse. It's defined as a drop in blood pressure systolic of greater than 20 from a lying to standing position, with symptoms such as dizziness, lightheadedness, and syncope. Now, how many times have you seen patients come in with a collapse leading to a fall, investigated with a CT head, echocardiogram, 24-hour tape, blood test, antibiotics for UTI, prolonging admission, deconditioning, only for postural hypertension due to dehydration? So with that in mind, here is a simple 3-step approach to managing postural hypertension. Step number 1 is the 5 Ds. Dehydration is the most common cause. Give IV fluids and encourage all hydration. Deconditioning. Now, if you and I were stuck in a hospital bed for over a week, we would be deconditioned, let alone an elderly patient. So encourage them to sit out daily, get early physiotherapy assessment, and discharge them as soon as possible. Drugs, commonly antihypertensives, diuretics, antipsychotics, and alcohol. A lot of elderly patients have polypharmacy, so stop what drugs that you can. Diseases, chronic diseases such as type 2 diabetes, heart failure, particularly right-sided, and cerebrovascular disease. And finally, diet. Large heavy meals in elderly patients can cause postprandial hypertension. So encourage them to eat smaller meals spread throughout the day and either stop or limit the caffeine intake. Step number 2. You've completed step number 1. Now recheck the lying and standing blood pressure. Usually the nurses or the physiotherapists do this, but be active. Do it yourself. Now, if the patient still has postural drop but is not symptomatic, you do not need to do anything further. Step number 3. The patient still has a symptomatic postural drop. This is divided into Part A and Part B. Part A. There are 3 uncommon causes of postural hypertension. Number 1 is neurological. Neurodegenerative disorders such as multisystem atrophy or Parkinson's disease can cause autonomic postural hypertension. So do a full neuro exam. Look for Parkinsonism or cerebellar features. Also, spinal cord infarcts or Guillain-Barré syndrome. Number 2 is infiltrative. Paraneoplastic antibodies or amyloid deposits can affect the autonomic nerves. Also, HIV, syphilis, or rarely Lyme's disease. Thirdly is endocrine. Look for any features of adrenal insufficiency and consider checking the cortisol level. Part B. If there are no signs of those 3 uncommon conditions and the patient does not have severe heart failure, then consider treating the postural hypertension with fludrocortisone, midodrine, or pyridostigmine. Refer to your local geriatric guideline for the titration of these medications. Next time you see a patient with postural hypertension, give this simple approach a go. And if it's helpful, then don't forget to subscribe.